Good morning and good afternoon, everyone, depending on which part of Canada you're in. Thank you all for joining us today. This is a very, very exciting time for us. Yesterday, we launched our Stroke Month report, our annual report, entitled Lives Disrupted, the Impact of Stroke on Women. We've had phenomenal interest and uptake, and we're really pleased today to be able to share this with you in more detail. Please submit your questions. We'd love to hear from you. We want to know what you're thinking about this report and some of the science behind it. So we look forward to hearing from you. Just to introduce our speakers, we have some very Canada-leading, top-notch speakers with us today. I'll do a brief intro, so I'm not the top-notch speaker. Dr. Thalia Field, who's a stroke neurologist in the Vancouver Stroke Program and the University of British Columbia. She will be speaking with us on the acute and prevention sides of stroke with women. Dr. Anita Mountain from Halifax is going to be speaking to us. She's a physiatrist, physical rehab medicine specialist, and she's going to be speaking to us on the recovery side, which is a very, very important issue for women in stroke. Unfortunately, Lynn Stacy, who is one of our spokespeople, who's a woman with lived experience, is not able to join us today, but we wish Lynn well. She's feeling unwell today. So first of all, I just want to let you know from conflict of interest, Anita and myself have nothing to declare. Thalia has one declaration, which is not directly related to this talk. So just a brief introduction. Yesterday we released our annual stroke report. It focuses on stroke in women, and we're really looking at it from multiple aspects. Women as the person who experiences the stroke, but also the role of women as caregivers to family members, spouses, parents, children who've had a stroke, and how that impacts their lives. We're then going to talk a little bit about women at the time stroke hit, at the onset of stroke, when symptoms first appear, look at one of the major risk factors for stroke in women, especially elderly women, which is atrial fibrillation. And then Anita will speak about rehabilitation recovery challenges. What we've learned from this report in doing this and all the research we've reviewed is we're really at the very beginning of this journey. For many years now, we've known significant differences between men and women with heart disease. Presentation is different, how they react to certain medications is different, the sensitivity of tests are different. We're not clear on those differences in women and stroke at this point. It's very new, and so we have a lot of understanding, but I think this report really launches that line of inquiry for all of us. So what we know in Canada, that every 17 minutes a woman has a stroke. That's 85 strokes a day across Canada. That stroke disproportionately affects women, and the average age of onset is actually different for men and women. A woman's average or median age is 78, whereas a man it's only 72. So that's a big gap, and that really addresses some of the other issues around how well women do and the increased mortality. We know that there's 3 high-risk periods for women, starting at pregnancy, and then during and after menopause, and finally with the elderly woman. As you can see with the average age, women are older, and that's women risk. We also know that more women die of stroke. 18 women die every day of stroke in Canada, and although we've had a decline in mortality over the last several years, the decline for men is going faster than women. We also know that for women, some of the reasons for the increased mortality are their advanced age. We know that when they experience a stroke, it's often more serious or worse symptoms. And we know that often elderly women have limited pre-stroke function. So they've already had some compromise. So at the time of their stroke, it's that much worse. The presence of atrial fibrillation is a major factor, and Thalia will speak more about that later. So in our Stroke Month report, the other thing we want to highlight is participation in research. We know that 2/3 of research on heart disease and stroke is on men. That's not necessarily done intentionally. It's the reality of often these studies will limit participation to an age of under 80 years old, and most of our women with stroke are older than that. It's also will often exclude women of childbearing age, and so that includes a big chunk of women. It also, women we've learned through in the social psychological realm tend to be more risk averse. They tend not to be as willing to try new drugs or during test phase as a man would, and that limits participation as well. I will now turn this over to Dr. Thalia Field to talk to us about acute stroke in women. Thank you.
Thanks very much, Patty, and it's my pleasure to be speaking to you guys today. My name is Thalia Field, and I'm a stroke neurologist in Vancouver. Just to give you some more information about issues that affect women in particular around the time that they present with stroke. Next slide. So as we've discussed before, women face both biological and social hurdles that partially explain the disparities that we see in stroke, both in terms of immediate and long-term outcomes. I've circled some of the more germane challenges that affect women around the time of stroke and presentation. Some challenges biologically include that age disparity, which can contribute to a difference in functional outcomes and increased presence of comorbidities, including atrial fibrillation, which I'll speak about. And also some social challenges. Being older may mean that you're more likely to live alone, outlive your spouse, and have fewer home supports, and thus have less access possibly to acute care, as well as long-term therapies. And then there are challenges that women may face in terms of misdiagnosis. So just moving ahead. So we know that most people that are admitted to stroke, admitted with stroke to hospital, have at least one risk factor for stroke. And those typical vascular risk factors that we think about are hypertension, high cholesterol, smoking, diabetes, and atrial fibrillation, as we've spoken about before. So with respect to women, being older is part of it, and more women are likely to have hypertension, which is the #1 modifiable risk factor for stroke, atrial fibrillation, which causes the most serious strokes, as well as history of prior stroke and TIA. And part of that is explained by the fact that they may be older at the time of stroke onset. And also contributing to those longer term outcomes are that the best known predictors that we are aware of for stroke outcome are age and stroke severity. And again, women are likely to be older, which gives you worse capacity for functional outcomes. And again, women are more likely to have strokes from atrial fibrillation, and I'll speak more about that in a minute. So as we know with stroke, in the acute phase, time is brain. So earlier treatment may lead to better prognosis. And interestingly, when we look at administrative data over time in this country, as well as in others, we know that women have longer acute treatment times and are less likely to receive the best standards of care. That includes being less likely to receive clot-busting drugs such as TPA, as well as endovascular therapy, where you're actually physically going in and pulling the clot out that's blocking an artery and starving the brain of blood. In addition to being less likely to receive treatments, when women receive them, on average, there are longer times for TPA administration as well as endovascular therapy. When women are admitted to hospital, they're less likely to get a specialist as their primary caregiver in the form of a neurologist. They're more likely to be admitted to family practice. And also in keeping with those trends, unfortunately, women are likelier to die within 1 week of having their stroke than men. And again, part of this is explained by biological factors, but as Patty mentioned, we're only beginning to further understand some of the more complex social factors and other factors related to bias and other issues, which may lead to some of these different outcomes. Some of the social challenges, as I've mentioned, that are faced by women is that being older at the time of your stroke onset and having a longer life expectancy than men overall means that you may be more likely to outlive your spouse, be living alone, and thus no one may be able to call for emergency help with stroke symptoms. Unfortunately, we found in a recent survey that a large proportion of women are not fully aware of stroke risk factors and may not recognize signs of stroke and know to call for help. So there may be that lack of recognition as well. We also have the challenge as women of having more misdiagnoses. I am pleased to have participated in a study with my colleague, Dr. Sheila Coots, where we were looking at symptoms that weren't traditionally considered as quote unquote high risk associated with minor stroke or TIA. And we found that women, more than men, were likelier to be associated with having some of these more atypical symptoms, and thus were more exposed to being likely to be misdiagnosed if they presented with minor stroke or TIA. And this is very important because minor stroke or TIA can often be a warning sign that a bigger event is going to occur over the short term. One of the reasons that we can think about is that women also have a higher susceptibility to migraine, and sometimes migraine can present with atypical transient neurologic symptoms that may be stroke mimics. So women may have a higher likelihood to be diagnosed with migraine when they may be having stroke symptoms. But this doesn't fully explain the disparities, and further research is certainly needed to further understand some of the other underpinnings behind this gender and sex gap with respect to stroke recognition and stroke outcomes. Further research that we've worked on together with the Heart and Stroke Foundation have also found that these trends continue when patients continue through the acute care system. They're more likely to be waiting in hospital without active medical treatment for further placement in long-term care. They are less likely to be discharged to a rehab facility. And they are more likely thus to be discharged to long-term care. And part of that is just due to the fact that women are older and may not have home supports. And you need some help at home after you've been discharged from a stroke, even if you're able to go home with a level of independent function. So as Patty mentioned, one of the high-risk times in a woman's life for stroke is actually in the first part of their life when women may become pregnant. Women who are pregnant are 3 times as likely to experience stroke than other women the same age. And that can be mediated by a number of different factors. During pregnancy, as we know, the body changes. There are changes in the amount of blood volume that are circulating through the body and the way that the blood flows. There can be blood pooling in the venous system, which can lead to clots forming. Changes in blood pressure may lead to venous clots passing on to the arterial side, say if there's a hole in the heart. And also there are hormonal changes that increase risk of stroke. Some hormonal changes during pregnancy can lead to problems with clotting. And also around the time of delivery, there are problems that can develop in blood vessels due to changes from hormones that kind of relax body tissues such as connective tissues, and that can make the arteries more susceptible to tears. So women are not just susceptible during pregnancy, in particular during their last trimester, but it's also that immediate period around delivery where those hormones have relaxed connective tissues, and as well inflammation can raise clotting risks as well. So certain complications of pregnancy also increase risk of stroke both during pregnancy, and as well they can increase, they're associated with risk of stroke later in life. For example, preeclampsia and gestational diabetes increase risk of stroke during pregnancy, and as well they are associated with an increased risk of premature cardiovascular death even several decades later. In terms of reasons why women may die from stroke in pregnancy, intracranial hemorrhage is the main cause of death, and we know that because that's the most deadly cause of stroke. But women are at risk of stroke both due to clotting for the reasons that I've explained before, and as well due to intracranial hemorrhage because of those changes in blood volume and the way that blood moves. So as we mentioned before, atrial fibrillation is a major risk for stroke, and in particular, it's a major risk for stroke in older women. Overall, men proportionately are at higher risk of developing atrial fibrillation, but because women have a longer life expectancy, and because atrial fibrillation is a condition that tends to affect older people, there are higher absolute numbers of women that are living with atrial fibrillation. And as we've explained before, it's a major risk of stroke. The heart doesn't pump effectively during atrial fibrillation, blood can pool and form clots, and there also may be additional hormonal changes that may affect clotting and other neurohormonal changes that raise the risk of stroke. And as we know, atrial fibrillation is a major risk of stroke. The clots that form in the heart can be large, and they can also cause major strokes. And by the age of 80, both for men and women, atrial fibrillation will comprise about a quarter of the attributable risk of stroke, as opposed to people who are younger. Women who have atrial fibrillation may also have more symptoms. They may have a higher frequency of palpitations, shortness of breath, effort intolerance, lightheadedness, and other issues that relate to the heart beating too quickly for the body. That being said, often as stroke neurologists, the first time that we see people present with atrial fibrillation can sometimes be when they present with their stroke. So although some people are symptomatic with their arrhythmias with atrial fibrillation, this isn't true for everyone. As I mentioned before, strokes due to atrial fibrillation tend on average to be more severe, more disabling, and more likely to be fatal than other strokes. And the reason mainly that we think about is because the clots in atrial fibrillation tend to be very large. They're less likely to be taken apart by acute clot busting drugs such as TPA, and patients are much more likely to need more aggressive treatments such as endovascular therapy. And as you can see, so on that top picture, it's a pathology picture of a heart, and you can see that there's a very large clot that's formed there in the left atrial appendage. And underneath is an example of a major stroke that's kind of the typical type of big stroke that we can see with atrial fibrillation. The major main branching points of the artery can be blocked by these very large clots and cause very large strokes. So we know that for stroke prevention in atrial fibrillation, that anticoagulation as opposed to antiplatelet drugs are the main way to reduce risk of stroke. People who are therapeutically anticoagulated have their risk of stroke reduced by about 2/3 as compared to people who are not on anticoagulation at all. Unfortunately, similarly with trends that we've seen with women in acute stroke receiving poorer standards of care, this also extends to secondary prevention. And we know that women who have atrial fibrillation who are at risk of stroke are unfortunately less likely to receive anticoagulation that's therapeutic. Part of it may be concerns due to an inability to monitor because women may be older and in long-term care. Part of it may be due to concerns about frailty or physiology. But at the end of the day, if you're not therapeutically anticoagulated, if you're on a lower dose of blood thinner than is needed for your body size and your kidney function and everything else, you are not adequately protected against stroke. Another challenge that women face with regards to knowing what the best treatments are for secondary prevention is that women are underrepresented in clinical trials. This is both true of clinical trials relating to the newer blood thinners for atrial fibrillation, but it's also a trend that affects both acute stroke and secondary stroke prevention trials overall. Again, part of that may be attributable to the fact that women are older and have more comorbidities on average at the time of their strokes, so they may not necessarily qualify for clinical trials based on their exclusion criteria. But there are also social factors where women may be more risk averse or more reluctant to participate due to social roles. So there needs to be more research into why women refuse participation in clinical trials, and some dedicated strategies that we can use to improve participation so that we truly know which treatments are best for women with respect to cardiovascular disease. So I'll turn things over now to my colleague, Dr. Anita Mountain. Thanks very much.
Great. Thank you, Thalia. The next part of the presentation will focus on the issue of stroke rehabilitation and recovery and the outcomes and challenges that women face. So when we look at some of the literature on this topic, we can see that access and outcomes of rehabilitation are not equal between men and women, but we yet don't entirely understand why these differences exist. overall women are less likely to become independent in their ADLs. They report worse quality of life. And although some of this may be explained by the fact that there's an increased incidence of stroke as women are older, and that they may be frailer and have more comorbidities at this time, this is not the complete answer, because we also see the same trend towards reduced functional recovery in younger women as well. Next. See the advanced slide, Patty. Oh, actually, just back one more. Oh, okay, sorry, it popped up already. Excuse me. So if we, the pop-up there, if we review the numbers that Dr. Field had showed us earlier, we see that less women are discharged directly to inpatient rehabilitation from acute care. And we also see that more people are discharged directly to long-term care from acute care. And of course, this is really important because that's a large number of people who are not being sent to inpatient rehabilitation, so they're not able to take advantage of that early intense rehab, which we know is the thing that helps to reduce disability after somebody has had an established stroke. Now, next slide, thank you. So this next slide looks at some details about admissions to rehab facilities, and it's based on some CIHI data, I believe, from 2015. And so we see that, in fact, more men than women were admitted to rehab facilities. So 46% of the people admitted were females, while 54% are male. We see that women are older at the time of admission to rehab, so a mean difference from 72.7 years to 68.5. Women who are deemed to be candidates for rehab, though, and are accepted to rehab programs, are not waiting longer to get to rehab. And so that's really important that at least those who are accepted to rehab are getting there in a timely manner. And the length of stays within rehab inpatient facilities are basically equal, the median being the same between females and males. I think it'd be interesting, however, to look at this data more in terms of some stratification by age and severity of stroke, and I wonder if some differences might be seen if we looked at it in those ways. Next slide. So this next slide looks at some data from the CIHI as well, and so this is some of the information on the functional independence measure, which is the main sort of functional independence measure that's used and captured in CIHI. And so that we can see that at the time of admission to rehabilitation, that women tend to have a lower FIM score than men, a difference of 71 versus 74. At discharge, women are discharged at a lower functional level as well. So men tend to be discharged at a higher level. But they're not making necessarily more gains. We can see that the change in FIM score is actually equal or relatively equal between men and women. So they definitely do benefit equally with rehabilitation therapies. But of course, the concern is that not as many women are being admitted for that rehabilitation. Next slide. So this next slide looks at some of the data from a paper that was published in 2015. And this was a very interesting paper. It looked at the trends and projections of the prevalence of individuals experiencing the effects of stroke in Canada. And so, although we know that the incidence of stroke is higher in men, so approximately 52% versus 48% for women, the overall population prevalence for stroke was higher for women, meaning that there are actually more women who are living with the effects of the stroke. And the authors here defined effect as being somebody who had a diagnosis of a stroke resulting in a cognitive or physical effect lasting more than 6 months. Next slide. So this table, I realize, is busy, but we'll try to highlight some of the important points. So they looked at where the people who were experiencing the effects of stroke lived. And so next, there should be just a pop-up there, Patty, if you advance. Oh, it's not coming up right. Okay, well, I'll walk you through it. So, so we found that for women and men, for people living in the community, that in fact there were more men who were living in the community with the effects of stroke, and so 92% of men were in the community versus 84% of women. And so correspondingly, there were more women who were living in long-term care facilities, so 8 versus 16%, which is really quite a large difference. And if you look at the sort of highlighted data there, this looks at, which I realize is hard to read, you will see that this looks at the numbers of population of people living in long-term care facilities. And so at the young age, at age 12 to 39, there are actually more men who were in long-term care facilities or home for the aged, as they mentioned, which may be a variety of different settings. The number of men and women is similar in the 40 to 49 age range. And from 50 years onwards, there are more women who live in a long-term care facility compared to men. And this is really important because when you look at the absolute population number, so as Dr. Field had mentioned, there are more women, and there's more women in the Canadian population as aging happens. But there's really not a difference in the population until you reach the age of 65. And so that's really quite interesting. Next slide. So this next study looked at some of the gender differences in stroke incident and post-stroke disability. And this is data that was analyzed from the Framingham Heart Study. And so as most of you would know, this was a very large cohort study that followed people up to even 56 years. So what they found, I'm assuming my highlights won't work, Patty, so I won't ask you to advance there. But what they found is that women were significantly older at the time of their first stroke, and we've already heard that. They have a higher stroke incidence above age 85, lower at all other ages, but also had an overall higher lifetime risk of stroke at all ages. And in the acute phase, and at 3 to 6 months post-stroke, women were more disabled in all the areas of ADLs that you see there, so eating, dressing, grooming, and also in functional mobility. And we're more likely to be single, so this speaks to the availability of having a caregiver or a spouse at home who might be able to provide care for you. So only 22% of the women were married versus 74% of men, so that's quite a wide range. And they were also found in this analysis of this data to be 3.5 times more likely to be institutionalized. Next slide. But the fact that women are older at the time of stroke with more comorbidities does not explain all the differences that we see in functional outcomes after stroke. So this paper here investigated the sex-specific, very long-term functional outcomes after TIA and ischemic stroke. And they looked at that in a younger cohort, so in those aged 18 to 50 years. And this was a cohort of 619 patients who had a mean follow-up of 15 years. And they assessed functional outcomes at 2 different points. And so they looked at it between 2009 and 2011, and then again at 2014 and 2015. And so when they looked at predictors of poor functional outcome, and you can see the results there for the numbers for modified Rankin scale, and just to remind everyone, the higher the score on the modified Rankin scale, the more disability, with 6 being dead. What they found was that predictors for poor functional outcomes on the modified Rankin scale were associated with a higher NIHSS score, so a higher stroke severity, which makes sense, increased stroke severity, higher incidence of poor outcomes. We know that's one of the very strong predictors of functional outcomes, but also, surprisingly, it was associated with female sex. And this was also the case when they looked at their other main outcome measure, which was the instrumental activities of daily living scale. So these results really highlight that importance of looking for other factors rather than just explaining the poor functional outcomes that women experience on advanced age and more comorbidities. Next slide. So what are some of the other differences? So there have been many studies that have looked at some of the other differences that some of which we haven't already discussed today. So things such as the fact that women may have an increased incidence of post-stroke depression, lower health related quality of life, more fatigue, and more cognitive effects. There's also a higher rate of relationship breakdowns, particularly when the woman is the partner who has had the stroke. And women have higher rates of caregiver stress. Women caregivers tend to find the emotional and cognitive and behavioral sequelae of stroke harder to deal with than the physical impairment. And if you think of it, it's those emotional, behavioral, and cognitive impairments that tend to be the ones that are present 24/7. And they're also the ones that are more difficult to get outside help or support to deal with. So rather than having home care or someone come in and assist you with a physical task, you really are dealing with those emotional or behavioral personality changes, cognitive effects ongoing throughout the day. And we also know that women are less likely to have outside help for those physical tasks. So they're even taking on more of the burden of caregiving. So not even getting assistance for the things that they can get assistance for, compared to men who are more likely to accept outside help if they're in the role of a caregiver. So what are some of these potential reasons for these disparities? Well, we've talked already about some of them. The fact that women tend to be older at the time of stroke, have more severe strokes, and have a larger burden of comorbidity at the time of their stroke, maybe more frailer. But women are also less likely to have a spouse at home to act as a caregiver. And even if they do have a partner, the poll that was conducted by the Heart and Stroke Foundation found that less than half, so I think it was 47% of women felt that their spouse would care for them if they had a stroke, compared to 55% of men who said that their spouse would care for them after stroke. And having a spouse or caregiver at home who will care for you is a significant factor in being able to return home after stroke, and also in being able to access important follow-up services. So if you need someone to have assistance with making and keeping track of appointments, having transportation to see your family doctor or follow up with your stroke neurologist or physiatrist. And of course, really important is being able to get to the outpatient therapies as well, or being able to access community programs such as stroke clubs or other community programs that help keep you invested and involved and involved in your community. And of course, in addition to all these potential reasons, there are other factors that we may not be even aware of yet, and there may be some other biological or physiological factors that definitely require more research. Next slide. So what are the next steps in rehabilitation recovery? Well, we know that these differences exist, and we know that our challenge now is to start to understand why those differences exist. And we really need to start challenging ourselves and asking questions about this. Do we need to look at making changes in the systems and models of delivery of rehabilitation programs? What models would best serve the unique needs of women, both younger and older? Would younger women, who may have more diversity of roles, responsibilities, be caring for children, parents, all sorts of other things, be more likely to participate in equally intense outpatient programs if they existed? I know certainly it seems daily on rounds I am talking to someone about the fact that early intensive rehab matters and that you need to take time now to invest in yourself and stay and participate in your rehabilitation. But, if a person was able to get the same intensity of rehabilitation, because oftentimes people are inpatient for that intensity, at least in the system that I work in, then would they be more likely to continue to participate in that program? It's an interesting question. Do some of our programs bias against older women by virtue, and older women and also, people with more severe stroke, who a large proportion of which would be women, by virtue of, some programs will have as admission criteria not accepting patients who are destined to long-term care. And so that would be a systemic bias, I would argue, against these women. We need to really look at how we deliver our programs. Are women more likely to participate in community group treatment programs and support groups? Do we need to look at more home-based programs or more programs supported by technology to allow women who are in rural areas or ones who maybe don't have that caregiver to transport them to the rehabilitation programs to allow them more access to the therapies that they need? And I think we also need to start looking at, do we have enough programs that really look at the unique stresses and needs of women as caregivers? Are we supporting our women caregivers enough? And I think really important also is to understand if there are differences in the pattern of neurorecovery between men and women. To be able to, tailor our specific therapeutic techniques, if there are, to women and men, and to allow us to maximize that important window of recovery after stroke. So now that it's clear that differences exist, I think the challenge really now is to research them more fully and to make sure that issues of gender are explicitly inherent in future trial designs. Thank you.
Thank you very much, Anita and Thalia. That is excellent presentation from both of you. I'm just going to wrap up now with summarizing some of the key messages that you've heard today and that we highlight in our report. First of all, stroke disproportionately affects women. More women die, they have worse outcomes, and they're less likely to gain their independence. But what we know from our poll with women, losing their independence is the most important, worrisome thing for them. So we really have to be sensitive to that. Women face unique challenges and have stroke risks at different stages of their life. Elderly women face the greatest burden, and that atrial fibrillation is a much more significant risk factor for women, especially elderly women. The other key message is that stroke disrupts women's lives. It changes their roles, and again, it threatens their independence. As Anita pointed out, they're not getting the support they need, especially once they return to the community. There's not enough services to help them to have the follow-up appointments and engage in rehabilitation that they could really benefit from. So for all these reasons, we're calling on all of you to help us in our challenge with dealing with women who've had a stroke. So as healthcare providers and as heart and stroke staff, because we have all of you listening to us today, here are the things that we need to do and we need to work with the healthcare system to accomplish. Within the Canadian Stroke Best Practice Recommendations, through our 7th edition, which starts this fall, we're going to be taking a much closer look at the differences in care and treatment between men and women and doing more to highlight differences now that we're starting to understand them with women throughout the guidelines. So please pay attention as we release new guidelines and look for those differences. From now on, all of our evaluations of the healthcare system are going to take a sex and gender lens. So we will always be looking, as we did for this report, at differences at all levels of care and outcome. Also, at Heart and Stroke, with all of our new research grants that we are funding, there will be a requirement to have a sex and gender analysis done, unless there's a very good reason why you can't. But every researcher is expected to look at sex and gender as part of their study. Together with the healthcare system, we really need to look at expanding infrastructure and technology. The use of telestroke will really open up access to care for a lot of patients across the entire continuum, especially in the rehab and recovery phase. As we've heard, women don't always have someone to help drive them to services, but if we can bring it to them through technology, that will make some significant differences in recovery. We really need to look at rehabilitation, especially community-based, and access to that, because many areas, especially rural communities, don't have any access to rehab services within their local area, and that really puts people at a disadvantage. We want to have healthier, more positive environments, and really start and have an open dialogue about both men and women, the way their treatments are, what we know about the treatments, and the effectiveness of treatments between the genders. Another important thing we learned in doing this report is the opportunity for the interplay between traditional and Western medicines for our Indigenous people. We've had a great example at Six Nations just north of Brantford, where these two types of healthcare have come together to really provide a much more holistic approach to health for Indigenous peoples. And it's an excellent example of the value and benefits of both and working together. At this stage, I would like to thank everybody for participating. If you haven't already done so, please post your questions, and I will now turn it over to Elizabeth, who will read the questions to us, and our panelists will respond for you. Elizabeth?
Hi, thank you very much. So we have one question that's come in already. And again, please submit your questions so we can get right to them. Is there a theory to why preeclampsia and gestational diabetes in pregnancy leads to a higher risk of stroke after pregnancy?
Thalia, over to you.
Okay, it's not exactly clear. We kind of are operating under the theory that pregnancy and the reaction the body may have is kind of like a stress test for comorbidities that develop later in life. So that may contribute that may contribute somewhat. I mean, we know in general that risk of stroke is raised by previous strokes. So whether or not there's additional, that's a marker of an additional stress susceptibility with regards to the cardiovascular system early on with kind of permanent repercussions, or again, whether it's just this stress test theory at work, we're not entirely sure.
Okay, great. Thanks so much. We're still waiting for questions to come in, so we don't have too many right now. Oh, here's one. Are there any initiatives in the works for Canadian stroke best practices to enhance the profile of stroke research and care for LGBTQ2 individuals or persons with non-binary genders?
Thank you very much for that question. It's a really important question. That is an area that we're only just starting to understand. In all of the research we did for Stroke Month, there was only one paper that actually has started to address that issue, and especially for people who are undergoing sex change operations or hormonal therapies, what is the impact on the risk for stroke? Unfortunately, the research is only just starting to be thought of and talked about. We don't have the answers to that yet, but we were really encouraged to see that a couple of the review papers just published literally within the last 6 months are starting to ask those questions. So we're hoping to be able to follow that research, and we'll certainly bring you more information once it's available.
Okay, thanks very much. How can women on oral contraceptives reduce their risk of stroke?
Part of it is being aware of other stroke risk factors. So certainly you have to make sure that you are aware of your blood pressure status, make sure that one isn't hypertensive, make sure other vascular risk factors, if they're present, are controlled. We know that that smoking dramatically increases risk of stroke associated with oral contraceptives. And also migraine with aura in particular is also associated with increased risk of stroke with oral contraceptives. So in general, we recommend alternative methods of contraception in women who have migraine with aura.
Great, thanks very much. And can you give an example of how we can incorporate the importance of Indigenous medicine into our care of stroke patients, please?
Sure. So I think the really important thing is we shouldn't be prescribing that. If you want to incorporate it in, which I think we all should be doing, it's important to work within your community of Indigenous people and have that conversation with them. We had the opportunity to go to Six Nations, meet with their traditional medicine healers, as well as hear from the doctor, the family physician who's working with them, and how the two interact. So I think learning from that community is one thing, but what we've also understood is how important it is to work within the community in your local area. So we strongly encourage everybody to reach out to those communities, both on the traditional and Western medicine, and have an opportunity to have that dialogue with them. Because what we've discovered is it's actually quite different in each local area. So please, everybody, think about those opportunities and start to reach out.
And why are older women at a higher risk of hypertension?
I think, Patty, maybe you can comment on this too. I think it's just the absolute risk of age-associated problems that are distributed over a longer lifespan, as far as I'm aware.
And we're still don't fully understand that, but what we're seeing is that actually hypertension, part of it is, you know, if you have gestation hypertension during pregnancy, you're more likely to have it later in life. But we're also seeing a shift in the age where the onset of hypertension. In past years, we've seen that the age of hypertension in relation to stroke is starting to show up in the 60s and 70s. Our latest data is showing that we're actually seeing people in their 50s now with hypertension. A lot of it has to do with diet and lifestyle, that we know exercise, you know, the population right now doesn't have the same levels of physical activity as in past years, and that we rely a lot more on processed and ready-made foods, which generally have a higher sodium content, which is actually contributing to the hypertension. So lifestyle and just current circumstances and employment are really showing, having an impact on hypertension. And, you know, another social factor is now more women are out in the workforce than in past years, and that's another contributing factor as well.
And so just to clarify, with regards to older women being at higher risk, that's compared to older men?
So most of that's related to the fact that women live longer. It's a lot of it to do with the age factor, that there just is more women in the late 70s and 80s, and by virtue of that, there's more women with stroke.
Okay, thanks.
Allie?
And is there a difference to how women respond to exercise training compared to men post-stroke?
Anita?
Yep. So we know with the rehabilitation therapies, you know, that we haven't looked at the gender and sex differences explicitly in a lot of trials. Women and men both benefit from exercise training after stroke, and certainly in terms of improving strength and endurance, motor recovery, but also to help reduce the risk factors, so things like cholesterol and high blood pressure as well. So there would be, as far as we know at this point, equal response to people when they do it at the same intensity. There may be some differences in terms of women's uptake of exercise after stroke, and we even know in young women who haven't had stroke, looking at preventative, that still women are less likely to be physically active. So it's an important thing to have some further research on.
Great, thanks. And we have a question here. Is there, is there research being done around spontaneous coronary artery dissection and increased risk of stroke?
My colleague, Dr. Jacqueline Saw, is a cardiologist who's one of the national leaders in understanding spontaneous coronary artery dissection. Quite often it's associated with a condition called fibromuscular dysplasia, and it's the diagnosis may have different implications in different people. It's basically a disease that affects kind of the integrity of connective tissue and blood vessels. And there is overlap sometimes in women that have spontaneous coronary artery dissection and dissection in other blood vessels. But sometimes we can see dissection related to fibromuscular dysplasia just in the cervical arteries alone, so those that are supplying the brain as opposed to the heart. But there is some overlap. But again, kind of our awareness of this condition has just begun to expand, and much of that is due to Jackie's efforts and her national database related to this. So she'd be a wonderful person to speak more about that going forward.
Okay, thanks. And here's another question. Is there guidelines for monitoring or assessments that I should be asking my doctor about, considering I experience preeclampsia and HELLP syndrome? Should I be looking for annual assessments or, for example, every 5 years?
I don't think there are any firm guidelines with regards to post-pregnancy monitoring now. It just may be that I'm not aware of the new practice statement. There may be something about that. But I think for anybody in general, it's reasonable to be monitoring your blood pressure and seeing your family physician on an annual basis to make sure that your vascular risk factors are well controlled. And just with that knowledge that there may be an increased susceptibility as time goes on.
And Hypertension Canada has just released this year new guidelines around hypertension and pregnancy that do go into more detail about that, and we can certainly post that information on the web on our Stroke Best Practice website. But more frequent monitoring, at least annually, to monitor blood pressure after having preeclampsia or hypertension disorders of pregnancy would be really important.
And does practitioner gender affect diagnosis or stroke outcome?
We don't know. It may. I mean, certainly we know that women researchers are more attuned to gender differences with regards to medical research in general from what we're aware of from meta-analysis data. And it is possible that kind of the gender of the practitioner versus the gender of the patient may affect the interaction, but more research is needed, absolutely.
Does integrating PMF therapy and ADL activities help improve ADL performance?
I'm sorry, what was the first part of that question, Elizabeth?
Does integrating PMF therapy and ADL activities help to improve ADL performance?
Well, I mean, there certainly are a number of different therapeutic techniques that can be used. We know that intensity of therapy and repetition is important. In terms of PMF therapy, I don't know that there's been anything to show that specifically. That nothing new that I'm aware of. Maybe some older studies, but certainly in terms of improving activities of daily living after stroke, repetition and intensity are important.
Okay, thanks very much, Anita. And then we have one last question here around telestroke. Someone's asking what it is and how can people access it.
So telestroke is an opportunity where we use video conferencing to connect people or hospitals in rural communities or more remote communities with specialists. We know that we don't have stroke neurologists in every hospital in the country. We have 637 hospitals. So we want to ensure that people have access to those specialists so we can provide stroke care even if you're living further away. So telestroke is two-way video conferencing. It's being used across the healthcare system. For acute stroke, at the time of onset of symptoms, if you go to a community hospital, they can connect with in Thalia's case, from some of the remote areas in British Columbia, they can connect to Vancouver General, speak to Thalia or another stroke neurologist and get advice, look at the CT scans, and help make the decisions around whether a patient could receive clot-busting therapy with TPA. On the other side of the continuum, there's wonderful examples where in rural Manitoba, there's no speech-language pathologist at all. Yet a speech-language pathologist in Winnipeg who is retired was spending her time using an iPad, connecting to people after their stroke in remote areas and working with them for speech therapy. That's an excellent example. There's other examples of using telehealth where people in smaller communities can connect into a physical exercise group or into the rehab facility to get some guidance, to talk to a physiotherapist, and continue to do their exercises even though there is no program within their community. We are very underutilizing this. The Canadian Partnership for Stroke Recovery had launched a big research grant competition a couple of years ago with Heart and Stroke to look at models of using telehealth and specifically in the rehab realm to expand access to services. And those results are just starting to be finalized, and we're really excited to see them. So we can certainly share more with you on that, and they are on the strokebestpractices.ca website. But it's a way to connect experts with patients and to provide support for decision making and to actually deliver therapy across the whole continuum. And we all need to be thinking about how to use that more. So I think that was the last question. I'd like to take this opportunity to thank everybody for participating today, our speakers. Thank you to Elizabeth for all her organization and getting us up and going today and for moderating this session. And to all of you, we really like you to join us on this journey to really look at sex and gender differences across stroke, across heart disease, and hopefully try to reduce the gaps in care and services between men and women. So we call on all of you to help us do that. If you have any further questions, feel free to email them to the strokebestpractices.ca inbox, and we would be happy to address them for you after this webinar. So thank you all very much, and we wish you a great day.